Addressing burnout in a behavioral healthcare clinic through OD or organization development. Created by Group 4, including Jovinia Brandon, Gabrielle Caslow Johnson, and Felicia White. Introduction to the organization and problem. Contents including entry, contracting, data gathering, diagnosis and feedback, intervention, evaluation, and exit. This organization is a community-based behavioral health agency that offers people of all ages broad services for mental health and substance use disorder, as well as peer support, behavioral health assistance, psychiatric services, group therapy, and individual counseling. The clinical team is diverse and includes licensed social workers, nurse practitioners, psychiatrists, and care managers, all of who hold licenses from the New York State Office of Mental Health. Many of the organization's diverse patients face complex and financial barriers to receiving care. It offers a range of prices to ensure services are accessible to all, regardless of financial means, and accepts insurances such as Medicaid, Medicare, and most private insurance plans to further increase accessibility. These factors can contribute to workload stress among staff and create an environment where burnout may develop. Although healthcare is seen as reliable and financially secure, many who enter the field do not fully understand the emotional and physical demands that can lead to workplace burnout. Defining burnout isn't just about fatigue or being tired. It turns more into emotional exhaustion, reduced effectiveness, and can cause someone to switch professions altogether. Some causes of the burnout include emotional strain, lack of support, high turnover, decreased morale, and risk to service quality. The healthcare profession produces high emotional and physical demands. These demands come with long hours, high patient or client needs, and constant exposure to the trauma of others. When addressing the problem of healthcare professional burnout, it is important to look at how it affects an organization and how can we combat it. Burnout significantly impacts employees in healthcare, specifically behavioral healthcare. It can impact all staff, but therapists and caseworkers are affected the most, feeling it across individual, organizational, and client-level domains. This project was selected because although careers in healthcare are frequently seen as reliable and financially secure, many professionals who enter these fields without fully understanding the emotional and physical demands that can lead to workplace burnout.
To begin addressing workplace burnout, our first step is the entry stage, where we will focus on understanding the organization and ensuring ethical conditions for gathering honest feedback. During the entry stage, key ethical issues involve confidentiality and privacy. Staff may feel hesitant to provide honest feedback about burnout, supervision, workloads, or administrative challenges if they fear retaliation or that their responses can be tracked back to them. To address this, all surveys and focus group is anonymized and reported only in summary, ensuring psychological safety. The clients in this stage include 3 levels: intermediate clients, the primary clients, and ultimate clients. Our entry process begins by establishing a committee representing all areas of the organization to guide change efforts. We will then launch a pilot program for target interventions and subgroups of clinicians, managing weekly feedback, and conclude with a post-intervention pulse survey to compare baseline matrix to pilot outcomes and inform future rollout decisions. On the other hand, during the contracting stage, the focus is a bit different. While we will define the scope of the work and establish clear success matrix. The scope includes diagnosing the problem through data collection, surveys, focus groups, interviews, designing primarily interventions, implementing tools or workflow changes, and evaluating the results. The success matrix will be measured by lower turnover, more compatible ratio of administrative time to service time, higher morale, and higher quality of service given. In the contracting meetings, mutual consent and psychological safety are crucial. Leaderships must openly acknowledge potential contributions to burnout, and the organizational development team must clearly define their role as a consultant rather than a miracle worker. By these establishing shared expectations and agreed with the success matrix, the contract will ensure that the change is ethical, collaborative, and focused on measurable improvements to the organizational mental health and burnout.
So now on to data gathering. We're going to use a couple different methods to do this. The first is going to be quantitative metrics. This is going to be objective data from HR, finance, or the EMR to establish baselines. Some data is going to be things like turnover rates, which is how many voluntary exits were there over a specified period of time, absenteeism, which are sick leave patterns, such as spikes in people taking sick leave on Mondays or Fridays, and also service ratios. So how much time is spent directly with clients versus time spent on administrative tasks like documentation and supervision. Next method is going to be qualitative inquiry, things like focus groups, which would be segmented by demographics like recent grads, parents, or level of education. One-on-one interviews, which are going to be deep dives with specific individuals that have worked for the company for a long time or have previously voiced issues with the topic of burnout, and also exit interviews to get a thematic analysis of past departures. And then our last method is going to be a structural assessment. So that includes SOP reviews. So it's going to be analysis of current documentation requirements by governing bodies, policy and workflow audits. We're going to look at organization policies and workflows to determine burden on the staff, both in session and outside, like during supervisions, and also do preliminary surveys. So we're going to gather levels of burnout using tools such as the Maslach burnout inventory or the job satisfaction scale to determine burnout levels of burnout and job satisfaction. So to start synthesizing the data, we're going to use analytical methods to extract meaning from the information gathered. We're going to use quantitative analysis to identify statistical significance and objective trends. One way of doing that is through descriptive statistics. We're going to calculate the mean and median for caseloads and exhaustion scores to find outliers. Correlation analysis, we're going to test relationships. So does high admin time correlate with the low personal accomplishment? And then also segmentation, we're going to use a cluster analysis to compare at-risk groups like caseworkers versus therapists. And then in our qualitative analysis, which we're going to be extracting meaning and themes from these narratives, that includes coding and categorization, so tagging transcripts with codes like administrative burden or undervalued, frequency and saturation. We're going to be identifying dominant themes that appear repeatedly across different groups, and then we're going to do contrast analysis, so comparing perspectives between high-paid staff like therapists and low-paid staff like caseworkers.
In the diagnosis phase, one key ethical issue is the risk of misdiagnosing when there isn't a mutual honesty or agreement about the problem. If leadership pushes a more comfortable explanation, the organization development practitioner may end up labeling the issue wrong, which leads to failed interventions and loss of trust. To avoid this, we'll analyze the data carefully. Using quantitative information like interviews and open-ended responses is reviewed to find repeated themes and shared experiences, such as administrative burden or feeling undervalued. Then we will bring these quantitative data to basically validate those themes. For example, if people reported feeling overwhelmed by administrative tasks, we will look at whether the documented time spent on the paperwork actually correlates with the lower effectiveness of the scores. This will help us understand why those statistical patterns occur. By integrating both types of data, we can make more accurate diagnosis and identify interventions that address the root issue of these causes. During the feedback phase, there are a few important ethical issues we will keep in mind, like resistance, retaliation, informed consent, and transparency. Some organizations push back on the diagnosis because they don't agree with the findings or don't want to face issues that might be expensive or uncomfortable to fix. There are also risks that people could face backlash if the feedback isn't anonymous enough, which is why confidentiality and clear communication are so important. Employees deserve to know what the data is being collected, why it's being used, and who will see it. To synthesize the data, we will use summaries, anonymized survey results, and themes from interviews to build a clear narrative about the organization's overall health without revealing any identifiable details. After that, we will partner with the leadership to make sense of the patterns and decide which root causes to tackle first, aiming for solutions that have real impact but are still doable. To reduce resistance to change, education becomes a key intervention. Providing credible research, evidence, and training helps people understand why change is necessary and minimize pushback. Finally, we will focus on what's controllable and avoid overwhelming the organization with excessive numbers of recommendations. Presenting a small set of achievable, high-impact actions make the feedback easier to accept and increase the likelihood of successful implementations.
So now we get to intervention. We came up with 5 different ways that we plan to intervene. The first one would be to create dedicated documentation and administrative time for all staff to reduce overwhelm related to administrative tasks. This will allow people to focus solely on clients during client time, improving service quality as well. Our second one is a crisis response differential. So this would be a tiered pay structure to acknowledge and compensate for the high intensity, low resource nature of employees in behavioral healthcare. And this can directly address feelings of being undervalued. Third, we have our comprehensive education on support systems. For this one, we decided that we would create a lunch and learn style training to get staff familiar with tools like the EMR, Outlook, etc., to increase productivity and also give staff a break to socialize. Number 4, we have implementing digital tools like AI documentation. So these would be HIPAA-compliant AI documentation software across all roles, not just those higher paid medical doctors, to improve documentation times and reduce documentation burden. And then our last one would be to focus on mindfulness and personal health. We would create a standard bank of mental health days, probably 2 or 3, that can be used, no questions asked, for staff to focus back on themselves. So now finally, our evaluation and our exit phase. Our evaluation consists of looking at our hard metrics and our soft metrics. Our hard metrics are tangible data points like, do we have a lower turnover rate? Are people less likely to leave the organization after our intervention stage? Do we have lower rates of absenteeism? Have initiatives like mental health days reduced rates of absenteeism? And do we have higher efficiency? Is there a decrease in time staff spend on documentation and admin tasks? Then you also have the soft metrics. What is the current experience of staff after our intervention? We would re-administer surveys and tests to determine employee experience. We would do the Maslow Burnout inventory, the job satisfaction scale, and also do engagement surveys to determine this employee experience after intervention. And then our exit phase, we would have a gradual handover. We as a consultant would move from being in control to sharing all documents and access to tools with the leadership of the organization. We would have our final report. So we would provide leadership with a comprehensive document outlining the whole process, including study data, diagnosis, actions taken, success metrics, and a guide for future improvement as well. And then we would have our formal conclusion, a final presentation after evaluation has concluded, to leadership or the board to discuss wins, acknowledge work, provide feedback, and officially conclude the intervention.
Here are our references used throughout this presentation. And thank you for listening.